Lesson 3. Recognizing Depression, a Self-Assessment and Qualification Procedure. This lesson is not intended to explain what depression is, nor to convince you that it is worth dealing with. Its purpose is one thing only: to provide tools for recognizing the state of the organism and making an appropriate decision. Without interpretation, without moral judgment, without psychological language. Depression is often mistaken for fatigue, burnout, or a life crisis, not because people do not want to see it, but because they lack objective points of reference. As a result, the decision to seek help is often postponed for months, and sometimes years. This lesson organizes that moment before therapy, pharmacology, or a diagnostic label appear. The starting point will be a screening self-assessment based on tools actually used in medicine and clinical research. These tools are not meant for self-treatment or for making diagnoses, but for assessing symptom severity and risk, and above all, for distinguishing situations that can still be monitored from those that require specialist consultation. This perspective will then be compared with the way depression is qualified by a psychiatrist on the basis of symptom duration, intensity, and impact on functioning. Without myths about mind reading and without reducing diagnosis to a single question or test. The goal of this lesson is not to answer the question, "Who are you?" but rather, "What state is your regulatory system in?" Only with this information does it make sense to move on to the next stage, that is, to methods that genuinely help restore balance, instead of merely masking symptoms temporarily. 1. What is assessed in depression? The scope of self-assessment. Before any tests or medical qualifications are introduced, one basic clarification is necessary: what exactly is assessed in depression? Neither self-assessment nor medical diagnosis concerns character, mental strength, or quality of life as such. They concern specific biological and functional processes that undergo predictable disturbances in a depressive state. Self-assessment does not consist of interpreting emotions, but of evaluating 3 areas of functioning that medicine recognizes as key in the identification of depression. These areas are measurable over time and can be compared with the organism's previous state. The first area consists of core symptoms, that is, elements without which clinical depression is not diagnosed. These include reduced drive and loss of the ability to experience pleasure. This does not refer to a temporary lack of motivation, but to a persistent decrease in vital energy and a lack of response to stimuli that previously brought relief or satisfaction. These symptoms are generalized and persist regardless of circumstances. The second area comprises biological symptoms, reflecting dysregulation of the nervous system. These include sleep disturbances, changes in circadian rhythm, chronic fatigue, and changes in appetite and body weight. These symptoms are diagnostically significant because they do not require psychological interpretation. They can be observed and compared over time. In clinical practice, they are among the most important indicators of depression severity. The third area is life functioning, that is, the capacity to act, make decisions, and maintain relationships. In depression, impaired functioning does not result from unwillingness or choice, but from a genuine reduction in system capacity. Everyday activities begin to require excessive effort, the range of activity narrows, and social contacts are reduced not due to preference, but due to lack of resources. Self-assessment therefore involves a simultaneous evaluation of these three areas and answering the question of whether the observed changes are temporary and situational, or generalized and persistent over time. The screening tools discussed later in this lesson do not replace this assessment, but help structure and clarify it. Only at this stage does it make sense to move on to measurement tools. Without understanding what is being measured, test results lose their meaning and become mere numbers. 2. Models of screening self-assessment used in depression. In psychiatry and clinical psychology, screening tests were not created as tools for making diagnoses independently, but as a way of standardizing the observation of symptoms that would otherwise remain descriptive and difficult to compare. Their primary function is to unify the language between the patient, the clinician, and scientific research. Instead of relying on subjective statements such as "I feel bad" or "I am exhausted," these tests allow for the assessment of the frequency, duration, and impact of specific phenomena on the functioning of the organism. Most commonly used diagnostic tools in depression were developed by academic institutions and public health organizations and have then been repeatedly validated in population and clinical studies. Their construction is not arbitrary. It is based on analysis of which symptoms most often co-occur with a diagnosis of depression and which best differentiate it from other states, such as transient stress, burnout, or adaptive reactions. As a result, these tests do not measure mood as such, but the functioning of the regulatory system over time. An important feature of these tools is their repeatability and comparability. The same set of questions, administered at different points in time, makes it possible to track changes in symptom severity regardless of interpretation. In clinical practice, this allows clinicians to assess whether a patient's condition is worsening, stabilizing, or improving. In self-assessment, it helps determine whether observed difficulties are temporary or persistent. For this reason, screening tests are not treated as verdicts, but as measurement tools whose value lies in their consistent and informed use. PHQ-9. The PHQ-9 is a brief, standardized screening tool consisting of 9 questions, each corresponding to one of the key symptoms of a depressive episode as defined in psychiatric practice. Its design is intentionally simple. It does not examine the causes of symptoms or their psychological meaning, but records their presence and frequency over time. Each of the 9 questions refers to a specific, observable area of functioning. In simplified terms, they cover loss of interest or ability to experience pleasure, low mood or feelings of sadness, sleep disturbances, both difficulty falling asleep and early awakening, chronic fatigue or lack of energy, changes in appetite or body weight, feelings of worthlessness or excessive guilt, difficulties with concentration and decision-making, psychomotor slowing or, conversely, agitation, thoughts about death, disappearing, or self-harm. All questions refer exclusively to the past 2 weeks, which is diagnostically crucial. The test does not ask about past episodes or general personality traits. It focuses on the current state of the nervous system. Each of the 9 items is rated on a 4-point frequency scale describing how often a given symptom occurred during the last 2 weeks. The scale includes for clearly defined levels, not at all, several days, more than half the days, and nearly every day. Technically, each level is assigned a score from 0 to 3, allowing the responses to be summed into a total score ranging from 0 to 27. Interpretation of the total score is quantitative rather than qualitative. In clinical practice, the commonly used ranges suggest approximately 0 to 4 points, minimal symptoms, no indications of clinical depression, observation over time is sufficient. 5 to 9 points, mild symptoms, possible low mood or early phase of regulatory disturbances, without clear criteria for depression. 10 to 14 points, moderate symptoms, a score suggesting clinically significant symptom severity and an indication for further assessment. 15 to 19 points, moderately severe symptoms, clear functional impairment, high probability of clinical depression. 20 to 27 points, severe symptoms, marked disorganization of functioning, urgent need for specialist evaluation. A score of greater than or equal to 10 points is of particular importance, as validation studies of the PHQ-9 identify it as a practical threshold indicating an increased likelihood of depression requiring further medical assessment. It should be emphasized, however, that interpretation always takes into account the impact of symptoms on functioning and their persistence over time, not merely the numerical score. Regardless of the total score, the presence of passive or active self-harm related thoughts, the ninth question, is treated as a separate safety signal and requires individual evaluation, even if the overall score falls within lower ranges. In summary, the PHQ-9 is a tool that quantifies the severity of depressive symptoms rather than determining their causes. Its value lies in allowing a repeatable and comparable assessment of whether observed difficulties exceed the threshold of ordinary strain and begin to meet criteria for a state requiring further medical evaluation. WHO 5. The WHO's 5 Well-Being Index is a brief screening tool developed by the World Health Organization, originally intended to monitor mental well-being in population-based studies. Unlike the PHQ-9, it was not designed to directly detect disease symptoms, but to assess the organism's capacity to maintain a basic state of well-being and regeneration. Over time, however, it has been shown that a low WHO-5 score is one of the most sensitive indicators associated with depression. The WHO-5 scale consists of 5 questions, each referring to a different, precisely defined aspect of mental well-being over the past 2 weeks. These questions address, respectively, cheerfulness, general calmness and relaxation, level of energy and vitality, quality of sleep as a source of regeneration, and the subjective sense that everyday life contains elements worth being interested in. Each of these areas reflects a different regulatory function of the organism, and only their combined assessment provides a picture of overall well-being. In contrast to symptom-focused tools, the WHO-5 does not ask about suffering, low mood, or functional difficulties. It assesses only whether the organism has still been able to generate positive states such as calmness, energy, or interest. The absence of these responses is interpreted not as an emotional problem, but as a signal that regulatory mechanisms are no longer functioning properly. Each of the 5 areas is rated on a 6-point frequency scale, ranging from complete absence of the given state to its presence almost all the time. Technically, responses are scored on a 0 to 5 scale, yielding a raw score from 0 to 25, which is then converted into a percentage scale from 0 to 100. In clinical practice, a score above 50 is treated as a significant signal of reduced well-being and an indication for further assessment for depression or other regulatory disorders. HADSD. The HADS, Hospital Anxiety and Depression Scale, was developed by A. S. Zygmunt and R. P. Snaith in 1983 as a brief self-report scale for detecting anxiety and depression in outpatient and hospital settings. The key design idea was technical. The authors wanted to measure depression and anxiety in populations where physical symptoms, fatigue, insomnia, loss of appetite, might result from somatic illness. For this reason, the tool deliberately minimizes somatic components and focuses on more psychological and behavioral symptoms. HADS consists of 14 items divided into two subscales, HADS-A, anxiety, and HADS-D, depression, with 7 questions in each subscale. Each question has 4 response options, scored on a 0 to 3 scale, yielding a depression subscale score ranging from 0 to 21 points. The test assesses depression primarily through the lens of anhedonia and reduced pleasure drive, rather than through sleep, appetite, or purely physical fatigue. Technically, the questions can be understood as similar to the following. 1. Over the past few weeks, have you noticed a marked decrease in interest in things that previously felt naturally engaging to you? 2. Do you feel that everyday activities have become emotionally flat, even if they are not objectively difficult or demanding? 3. Have you noticed that you rarely experience joy or satisfaction from things that used to give you pleasure? 4. Do you have the impression that your emotional reactions are muted or slowed compared to earlier periods of your life? 5. Do you feel internally low or emotionally heavy for a significant portion of the time, regardless of current events? 6. Do you find it harder than before to engage in everyday matters, even if they do not require much physical or mental effort? 7. Despite changes in circumstances, rest, or favorable conditions, do you still find it difficult to feel interest or pleasure in everyday experiences? Scoring is straightforward. You sum the points from the 7 depression-related questions, 0 to 3 each, obtaining a total score between 0 and 21. The standard threshold interpretation, commonly cited in studies and adaptations, is as follows: 0 to 7 points, normal range, no significant indications of depression according to HADSD. 8 to 10 points, borderline result, suggesting possible depression and indicating the need for further assessment. 11 to 21 points, abnormal result, strongly suggesting clinical depression or a significant pathological potential. 3. Confrontation with a psychiatrist, either limits of self-assessment. If screening tests indicate moderate or severe depressive symptoms, further self-diagnosis is no longer appropriate. At this point, contact with a psychiatrist is neither an option nor a suggestion, it is a necessity that must not be postponed. Any delay in seeking consultation increases the risk of worsening of the disorder and complications that the patient is often unable to recognize in themselves. Depression is not a static condition. It does not stay in place, nor does it resolve on its own. When left untreated, it tends to deepen, entrench symptoms, and progressively narrow psychological and life functioning. One of the most dangerous aspects of depression is that it distorts the individual's self-assessment of their condition. People with depression very often fail to see how much their well-being has deteriorated and how significantly the risk of self-destructive behaviors, including suicide attempts, has increased. This is not a matter of character or the dark thoughts, but the effect of impaired psychological regulation. For this reason, psychiatric evaluation should take place as soon as possible. A psychiatrist does not rely solely on the patient's declarations or test results. Direct clinical observation is of key importance, allowing the clinician to detect subtle yet significant signs, the degree of distractibility, speed of thinking, coherence of speech, quality of logical contact, visible mental exhaustion, psychomotor slowing, or agitation. These are elements that often escape family members, friends, and even the patient themselves, yet for an experienced psychiatrist they form the basis for assessing the depth of the disorder. Equally important is the fact that the psychiatrist performs careful diagnostic differentiation. Low mood does not always mean depression as an independent disorder. It may be a symptom of somatic conditions, such as hormonal disturbances or neurological diseases, a side effect of medications, or part of other mental disorders. Depression frequently co-occurs with anxiety disorders, phobias, and also with schizophrenia, where it is often one of the most serious risk factors for suicide. Such distinctions cannot be made without a personal medical examination. This must be stated clearly. The opinions of loved ones, conversations with friends, or online tests cannot replace a specialist's assessment. Not because they are worthless, but because they do not have access to the full clinical picture and lack the tools to evaluate risk. A psychiatrist works on the basis of knowledge, experience, and objective observation. This is precisely why their assessment is more reliable than any form of self-reassurance. The sooner an accurate diagnosis is made and treatment is initiated, the greater the chance of halting the progression of depression and achieving full functional recovery. Postponing a visit always works to the patient's disadvantage. In this sense, prompt contact with a psychiatrist is not a sign of weakness, but the only rational decision in the face of a disorder that carries a real risk to life. 4. Classification of depression in psychiatric assessment. After completing the psychiatric interview and examination, the physician classifies the depression. The purpose of this classification is not merely to describe symptoms, but to determine the mode of treatment and the level of patient safety required. This classification is based on three main axes: severity of symptoms, impact on functioning, and level of risk. Mild depression. Mild depression is diagnosed when symptoms are present and persistent but do not cause significant breakdown of functioning. The patient retains the ability to work, make decisions, and regulate behavior independently, although this requires considerable mental effort. Passive or occasional resignation thoughts may be absent or infrequent. In clinical practice, this form of depression does not require hospitalization. Treatment is conducted on an outpatient basis and may include observation, psychotherapy, and, depending on the clinical picture, pharmacotherapy. Close monitoring of symptom dynamics is crucial, as mild depression can deepen if left untreated. Moderate depression. Moderate depression is characterized by a clear reduction in functioning. The patient has difficulty performing everyday duties, concentration and decision-making are impaired, and biological symptoms, sleep, energy, circadian rhythm, are clearly disrupted. Anhedonia is usually present and persistent. At this level, the psychiatrist actively considers pharmacotherapy and more frequent follow-up visits. Treatment may still take place on an outpatient basis, but only if the patient remains capable of cooperation and there is no elevated suicide risk. Otherwise, the physician may recommend intensification of care, including temporary inpatient observation. Severe depression. Severe depression is a state in which there is a serious breakdown of psychological functioning. The patient may exhibit markedly slowed thinking, difficulty maintaining logical contact, intense hopelessness, and persistent anhedonia. Intrusive resignation or suicidal thoughts are common, and the capacity for independent appraisal of the situation is significantly impaired. In such cases, psychiatric hospitalization is not a failure or a last resort, but a standard measure to safeguard the patient's life and health. An inpatient stay enables continuous observation, rapid treatment adjustments, and assessment of response to pharmacotherapy under controlled conditions. The decision to hospitalize is based primarily on risk, not on the patient's subjective sense of their condition. 5. The key criterion: safety. Regardless of the formal severity level of depression, any presence of suicidal thoughts, loss of impulse control, or profound thought disorganization may lead to a decision for inpatient observation. In clinical practice, patient safety always takes precedence over psychological comfort or the patient's personal preferences. A psychiatrist does not threaten with hospitalization, but assesses whether the patient can safely remain outside the ward. If the answer is no, hospitalization becomes a component of treatment, not an escalation of it. Summary. Self-assessment makes sense only as an initial step. Screening tools help organize symptoms and identify the moment when low mood ceases to be a reaction to difficulties and begins to carry clinical significance. At this point, further self-checking loses its value, and contact with a psychiatrist becomes an absolute necessity. A specialist's evaluation does not consist in confirming test results, but in qualifying the depression, determining its severity, course, and level of risk. This qualification determines the mode of treatment: outpatient, intensified, or inpatient, and the scope of patient safety measures. The overriding criterion is always safety, not the patient's subjective sense of control. Depression does not resolve on its own and has a tendency to deepen. The earlier it is properly recognized and classified, the greater the chance of halting its progression and achieving full functional recovery. This lesson closes the diagnostic phase and prepares the ground for the next step: conscious, targeted treatment, in which non-medical factors may also play an important role, but only within the framework of a safely established diagnosis.